Thank you, Dr. Rohit. I think I must say thank you, Dr. Namrata, Dr. Mahipal, Gaurav, for giving me this opportunity. The only issue I have is I'm still dabbling what topic to speak on because before me, Dr. Tityals talked about a posterior polar, and I actually wanted to show my technique of dealing with posterior polar, which have pre-existing openings, complete opening from one equator to another equator through and through. So I thought I might change the topic. So I have another topic where I show my famous inverted T technique. So I'm still dabbling, but I guess I'll go with the polar technique because I saw some people ask about the what would we do if we had a pre-existing opening. So I would say I'll go with that topic to start with. So this is what it is. I call it the tech masala mix for the simple reason because you need a good machine, you need a set of skills, and you need to have a good combination of both. And here is a case, one of the recent few cases. This was a very good quality recording, so I thought I'd bring it on. The patient reported to me with both sides bilateral pre-existing PC opening, one edge to one edge. I have no financial interest in anything I talk about. I'll be talking about some cannulas which are designed by me, some other methodologies. So we will start with the surgical video. I'll fast forward a lot of steps because it's actually a 12-minute video. So we did publish this in 2009 and we modified this technique. We've actually done nearly 600 cases till now. This is the case where we see this is the PC opening. The PC is open from at least 11 o'clock to 5 o'clock complete. So I start by making an oval capsulorhexis. Now the oval capsulorhexis is a big advantage for me in case I do the D technique, which of course I'll be trying to show in this video. I can flip the D segment of the nucleus through this oval. And in case there is a PC rent, which of course we know there is a PC opening in this, we utilize to keep the IOL in the sulcus. As we see, it's a completely oval rhexis. Now the way, this is a cannula designed by me, it's a 23 gauge cannula with a bevel softly beveled up. I would go onto the nucleus surface and inject within the cortical plate. And you will see there are small little rings forming. This has to be a very gradual thing, knowing that the PC is open. Very small bursts of cataract. I think we have one of the largest series in polar cataracts in 2009, nearly 600 plus cataracts doing, and this technique works perfect. Low bottle height, low phacoemulsification parameters. Now what do? I first shave off the whole cortical matter on top of the nucleus. So you're noticing that I'm shaving off and freeing the edges. What this does for me is when I want to scoop the nucleus out, there's a complete path which is open for the nucleus to come out. So here I'm going to do a complete nuclear disc pull out. So I will engage with the phaco tip, higher vacuum, very low phaco, nudge it, bevel it, and make another. I've loosened it up. Now I'll get it into the anterior chamber. And since I have an oval rhexis, I just take it off as you would take a flat tire off a rim of the car. Now this is where the machine helps me. I'm using an APS mode in my Nidec machine. What it does for me is it holds on to the piece, and the moment the occlusion is about to break or just breaks, I just lose the vacuum. So I don't have the PC rushing up to my phaco tip. You will notice, I will show the last piece. There's a little small piece which you see now, see, and there is no surge because the moment the occlusion breaks, the PC doesn't come up to rise. Now, the second important step for the people who are watching is to know that before you pull out your instrument, you push in a viscoelastic. But don't push in a lot of viscoelastic, otherwise you'll be opening the anterior vitreous face and you'll have the cortical plate go inside. Next step is to remove the cortical plate. I am a very big fan of coaxial irrigation aspiration. So start with the subincisional area, because when you do the subincisional area, this is one of the most tough places to hang. So do that first. Then I do a centripetal irrigation aspiration, again described by us in the article. You pull each side to the center, but never pull out the whole cortical plate. The cortical plate, once you notice, I'm peeling all the edges, and just like a flower petal which is attached in the center, then when finally everything is detached, now I just go on a high vacuum and I flip it with the flick of my wrist and get the whole cortical plate up. And you see that the posterior polar cataract is coming up. And the moment this is up, we will see a complete PC opening. There it is. Now, don't panic. You already know it is there. So I don't come out. I continue with my coaxial irrigation aspiration. Again, a very good set of a machine to do this for you. It should be very predictable. You notice during the whole procedure, the anterior vitreous face is not disturbed because I am not aspirating at a full blast. I have a low flow rate, a moderate vacuum, and I'm just peeling the cortex in towards the center, making sure I'm working only at the iris plane. Now, once this is done, you can still see the posterior capsular flap flipping there. There is no fluid going into the vitreous face is still intact, and I'm continuing doing my irrigation aspiration. Now, this needs skill, and of course, you need a technology to help you here. Here we're using both. Now, the most tricky part again of this cortical plate, though we have loosened it in the subincisional area, but that will be giving me some trouble again. But since I know I've already freed that in my first step, so I'm not much bothered about it. I'll just fast forward the video slightly here. Now, somebody can use a bimanual irrigation aspiration. It's their call. I am more comfortable with coaxial. Yes, I do use bimanual also sometimes. Now, this, since the last piece is going to come out, again, as it comes out, there is no surge. I'm just peeling the last piece and I just slow down, slowly motion, pull it away. And you see the PC is broken. There's no vitreous. Everything is perfect. Now, before I withdraw my irrigation aspiration coaxial cannula, I push in viscoelastic. Again, remember, do not push a lot of viscoelastic because you will be pushing this viscoelastic into the vitreous now. Now, I have an oval rhexis now I will start doing a vitrectomy here, making sure I didn't put enough viscoelastic initially so that I have enough anterior chamber distension. I will just remove the vitreous. I'm trying to go a little bit fast here. Now I inject very small little bit of methyl cellulose under the iris just to create enough space with the 27 gauge cannula. What this does for me is it creates a space between the iris and the anterior capsule because I'll be going in for an in-sulcus implantation. In this case, I did not want to do a posterior capsule capture on the anterior capsule because since this rupture was huge, I was afraid that when I tried to put it behind the anterior capsule, have an anterior capture, I might have an extension. So I decided to go in for a complete sulcus implantation and enlarge the wound. And I use a 3-piece lens. My personal favorite is a Technis. Now, as I go in and make sure that the leading loop is running parallel behind the iris, and I have created enough space there while I put the lens in. Now, as the lens is opening, I wait for the lens to open 3x4. Once this is done, I slowly dial the lens in place. Now, once this is done, we use a meiotic. I just want to make sure whether there's no vitreous because the vitrectomy was done. There's no vitreous there. I just jump the video. Okay, I'm jumping the video now. Now, before suturing, I will put a little amount of viscoelastic just under the wound. I've hydrated the wound. I jumped the step for hydrocortisone injection. Now, we just put a little bit of viscoelastic. And this is to make sure while I'm suturing, now I don't want the chamber to collapse. So I just put a little bit of viscoelastic just under the wound and I do my suturing. I complete the suture. I embed the suture in. And now I use a little bit of viscoelastic under the side port. I come from another opposite side port to do an iridectomy. Now this is again done. I did put some viscoelastic there under the side port to push the iris down so I could get a good grip to do a PI. I do a viscoelastic removal with the 27 gauge cannula, and this is how the case turned out to be. So this is something about the machine. What we used in this particular case was, I call it the APS. Now, what happens is the moment occlusion breaks, first of all, the moment occlusion happens, the machine starts ramping up the frequency and the duty cycle of the phaco. Now, this is how it happens. You see a slow rise time. The moment occlusion starts happening, the pump starts moving slowly, and then the pulsations, duty cycle, and the pulse frequency goes up. And the moment the occlusion breaks, the whole thing comes down. So for especially in the case like I did before, I think this technology really helped me. So I guess this is a good combination of tech Masala mix. Thank you.